Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from Italy, Professor Simon Pestillo. Professor Pestillo is a specialist in neurosurgery, adjunct professor at the St. Camillus International University of Health Sciences, where he is Guido Guglielmi Endowed Chair for Endovascular Neurosurgery. He is a member of the Vascular section of the EANS and a director of fellowship program in the Vascular and Endovascular Neurosurgery. He is also a visiting professor at the Department of Neurosurgery at the Hyogo College of Medicine, Japan. He has performed more than 1,000 endovascular neurosurgical procedures in Italy and abroad, and he is the author of 80 articles in international journals, including the European Guidelines on Treatment of Cerebral Aneurysms. He is a reviewer for most of the important international neurosurgery journals and author of 3 books on neurosurgical pathologies. He has participated as an invited speaker on numerous conferences in and around the world, and we are extremely grateful to him for accepting our invitation to be a speaker at webinars. And today he'll be talking about vascular and endovascular training in neurosurgery. The speaker for the second session of today is our honored guest from India, Professor Rupesh Kumar. Professor Rupesh is the Director of Neurosurgery at the MGM Healthcare, Chennai, India. He is a distinguished surgeon with over 20 years experience with expertise in the management of complex brain and spine tumors, minimally invasive cranial surgeries, and cerebrovascular surgeries. He has been associated with some of the most premier medical institutions in the country, such as NIMHANS and JIPMER, and he holds several important positions in the Indian Neurosurgical Society. To name a few, he is a convener of the YNS Forum of India, Secretary of the Skull-Based Surgery Society of India, founder and secretary of Society for Intraoperative Neurophysiology, executive committee member of the Neuroendoscopy Society of India, and also the Indian Society of Neuro-Oncology. He has over 52 impactful publications in various peer-reviewed journals and book chapters, and he is a reviewer of peer-reviewed and international journals. He has been honored with several awards for his outstanding contributions to neurosurgery in India. We are extremely honored to have him today at our webinars, and today he will be talking about extended endoscopic endonasal approach for Clival Chordomas. The chair for the first session of today is our distinguished faculty from the USA, Professor Sabarish Natarajan. Professor Natarajan originally hails from Madurai, India, and he is currently the Director of Brain Tumors, Skull Base and Cranial Neurosurgery, and he is also the consultant in Cerebrovascular and Surgical Neuro-Oncology Institute at the St. Vincent's Healthcare, Jacksonville, Florida. He is a member of the AANS, CNS, as well as the American Association of South Asian Neurosurgeons. He has been rewarded with several awards and honors for his outstanding contribution to neurosurgery. He is an hybrid trained neurosurgeon and specializes in both clipping as well as coiling for aneurysms. He is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Pestillo. The chair for the second session of today is our honored guest from the United Kingdom, Professor Ramesh Nair. Professor Nair is a consultant skull base and neurovascular surgeon and head of skull base and neurovascular surgery at the Charing Cross Hospital and St. Mary's Hospital, Imperial College Healthcare, NHS Trust, London. He is the executive editor of the Asian Journal of Neurosurgery and the associate editor of the British Journal of Neurosurgery. He is an invited faculty of the ACNS as well as the WFSNS educational course, and is also a member of the International Academy of Neuroanatomy. We are extremely grateful to him for accepting our invitation to chair the session of Professor Rupesh Kumar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would like to hand over this podium to our first chair, Professor Sabarish Natarajan.
Thank you, Professor Kato and Raja, for inviting me to chair this session. It's my pleasure to introduce our first speaker, Simon Pestillo. He is a well-established hybrid neurosurgeon with a training facility from the other side of Atlantic, and I'm excited to hear what his take is on hybrid neurosurgery, the future, and the training in vascular and hybrid neurosurgery. Please, Professor.
Thank you, Raja. Thank you, Professor Kato. Thank you, Professor Subin, for having me today with you. I'm very happy and honored to discuss with you. So thank you so much. It's a great honor to discuss with you the vascular and the vascular neurosurgery training almost in Europe. actually, I am one of the very few endovascular neurosurgeons in Europe, because normally, as you know, normally this part in Europe is done by neuroradiologists or radiologists. But I strongly believe that we should do everything that we can do to allow to neurosurgeons to do also the endovascular part. So let's start my talk. My first slide is to better explain which is the definition of a cerebrovascular neurosurgeon. Who is one who do open vascular surgery? Yes. Is one who do endovascular surgery, someone who do radiosurgery, and someone who knows about the critical care. So nowadays, a cerebrovascular neurosurgeon could have three definitions altogether. And a very important thing is that who is the specialist of the disease? No question is the neurosurgeon. And the specialist of the treatment could be an open vascular neurosurgeon, or an endovascular neurosurgeon, or an hybrid neurosurgeon. In fact, what does it mean, hybrid neurosurgeon and dual trained neurosurgeon? For hybrid neurosurgeon, we can affirm that is someone who perform both vascular, so open surgeries, and endovascular treatment. And the dual trained neurosurgeon is one who was trained in both treatments, but perform or open vascular or endovascular treatments. But the most important question when we talking about the training of vascular and of vascular pathologists is which is the future of open vascular neurosurgery. In this paper that was published recently by Michael Lawton and Michael Lang, they have discussed about these perspectives. And if we can see what happened during among the years regarding the surgery of brainstem cavernous malformation, we can see clearly that surgery in this for these lesions improved every year. Regarding AVMs, we know that probably for type 1 and type 2 AVMs, type 1, type 2, Spencer-Martin grade surgery remained the gold standard. And in fact, the surgeries for these lesions among the last 10 years was slightly increased. In fact, microsurgery is the first line therapy for most low-grade AVMs, and we can use embolization as a preoperative adjunct and radiosurgery for AVMs in deep and eloquent locations. And regarding the aneurysms, the open vascular treatment for these lesions changed among the years. In fact, during the last 20 years, surgery for the aneurysms decreased, but now surgery is reserved only for very complex cases. So open microsurgery is and should remain a cornerstone of neurosurgical culture because it offers anatomical insights and contact with pathology. And this is very important, that case volume is the secret of success because it develops experience, efficiency, and confidence. But should everyone be a vascular neurosurgeon? This is the other question. The best neurosurgeons will be needed to tackle the complex lesion that cannot be managed with other modalities. And the microvascular practice of the future will require subspecialization, collaborative team effort, and academic medical center, and a large catchment population. and everything of that have to funnel patients from hospital networks outside the region. And dexterity and meticulous application of microsurgical technique will remain the fundamental skills of the open vascular neurosurgery. But why should neurosurgeons do endovascular? This is a very important question. In 2016, this paper was published in Journal of Neurosurgery, and here you can clearly see that neurosurgeons had the less morbidity and mortality rates related to the treatment for unruptured and ruptured aneurysms compared to the neurologists and interventional neuroradiologists. So the authors have hypothesized that a lower incidence of complication in patients with aneurysm treated by neurosurgeons could potentially be correlated with the pre-fellowship training. And in conclusion, in their study, they have found that patients treated by neurosurgeons had improved outcomes compared to the others treated by neurologists and interventional neuroradiologists. A couple of months ago, I have launched this survey in Twitter, and I have asked which could be the treatment rate of endovascular procedures versus open procedures. So the majority of the people have chose the rate 90 endovascular and 10% open. Probably in Europe and I think probably also in North America, the rate could be 70 and 30%. But this is very interesting because nowadays with all the devices that we have, we can treat almost the 90% of the cases. So whether we like it or not, this is the present. To remain at the forefront of evaluating, caring for, and treating patients with cerebrovascular disease, vascular neurosurgery must evolve toward a specialty, mastering the knife as well as the catheter. It's time for neurosurgeons to start in training residents in endovascular neurosurgery in the same way we train neurosurgeons in every other neurosurgical discipline. Without question, no physician is experienced, qualified, and comfortable in dealing with a neurological emergency as the neurosurgeons. These sentences were published in Neurosurgery in 2006. This can demonstrate how North America is much more advanced compared to the Europe countries, because only now we have started to talk about this. So we have to run and to go at the same level of our North America colleagues. But which is the best method to train a cerebrovascular neurosurgeon? To train him like an hybrid neurosurgeon, or to be a vascular neurosurgeon or an endovascular neurosurgeon? I don't know which is the correct answer. In my experience, I have preferred to be only an endovascular neurosurgeon to push my boundaries as much as possible. But we know so many colleagues in North America that are a very excellent hybrid neurosurgeons. But this point is very important, I think. If neurosurgeons have completed fellowship training in only endovascular or only open surgical approaches, there is a risk that they may make overlap biased decision and have a limited option to offer their patient. Neurosurgeons with dual training will be in position to offer their patient a full comprehensive approach with possible less biased approach to manage aneurysm and may lead to potentially more favorable outcomes. The future of neurosurgery will be inseparable from the future of endovascular neurosurgery. we should be unbiased. So we should stop fighting and asking which is fighting and saying that my treatment is better than the other. But which is the best treatment for the patient? In fact, we are two faces of the same medal. This is very important. This is the normal evolution. In fact, the pioneers of endovascular neurosurgery was Fedor Serbinenko in 1974, a Russian neurosurgeon, and Guido Guglielmi, who is a neurosurgeon and Italian neurosurgeon, in 1991 started and the develop of the Guglielmi detachable coils. But what are the two milestones in vascular neurosurgery history? March 23, 1937 was reported the first clipping of an aneurysm, and March the 6th, 1990, the first aneurysm was embolized with a Guglielmi detachable coil. We should work to create a comprehensive training program for those who are interested in vascular or endovascular neurosurgery, almost in Europe. In fact, I am one of the panel member of the vascular section of the EANS, and in January 2020 we started to organize this basic endovascular course for neurosurgeons, and then it was a new edition in Amsterdam last year and this year. And even more this year in March, and we organized with Marco Censato the ENS bootcamp for vascular and endovascular neurosurgery in Milan. It was divided into part one with the web seminars, and the second part was an hands-on part in Milan with an international faculty. And we have organized, this is a little video to show how was the lineup, the workup of the we had microscopes. This is a Kinevo from Zeiss, and the faculty showed the techniques of the dissection of the vessels with a human placenta, and we had all the instruments from Takayama and clips to show how to do bypasses and clipping. And just close to this room, we had the endovascular simulators, where the trainees had the opportunity to try also the endovascular approaches in stroke and in the embolization of the aneurysms. So here you can see Marco Censato show to the others how approach the vessels, and here he tried to do also endovascular embolization of an aneurysm. It was very funny. We had also a live surgery from the Niguarda OR with Marco Censato that performed a bypass. So it was very interesting. And in parallel to the bootcamp, we have also created this new pathway that is for the first time in Europe. This is an European vascular and endovascular neurosurgery master study program. It's like a fellowship program. It's a 1-year course It is endorsed by the World Federation of Neurosurgical Societies, the Italian Societies of Neurosurgery, and the Italian Society of Neurology, Neurosurgeons, and Neuroradiologists. Here in the QR code, you can check all the link to the website. We can have only 10 participants. The next course, the deadline for the next course will be at the end of September, and the course will start on the March the 1st, 2024. We have a world-renowned faculty with colleagues that come from North America, South America, Europe, and Asia, and Japan. We have also a great special lecturer from some of the most experienced vascular neurosurgeons in the world. And I'm very happy to show you for the first time, this is the new lineup of the hosting centers. We will have 10 hosting centers for the next year course. 4 in Italy. We will have also Zurich with Luca Regli and Giuseppe Esposito, Göttingen, Madrid, Zagreb, Linz, and Barcelona. So we can offer the endovascular training or the open vascular training, or both with hybrid training path in Leeds and Barcelona. This is the program of this year, but it will be almost the same for the next year. We have organized one day for web lectures, and every month we will have one day on a very specific argument topic, and this is the list of the special lectures. And we have also 2 or 3 hands-on part in Rome, where the attendees will use all the Takayama instruments and Zeiss microscopes. We have 800 hours of clinical practice, 150 hours of theoretical part, and 40 hours of hands-on part. As said before, this course is endorsed by the World Federation of Neurosurgical Societies, the Italian Society of Neurosurgery, and the Italian Society of Neurosurgery, Neurology, and Neuroradiology. We have asked for the UMS approval, and the course is supported by Takayama Instruments, Zeiss, and Rapid Medical. Just a couple of pictures of the hands-on part. Here you can see the instruments provided by Takayama, and those are the top quality of the microsurgical instruments. And here the trainees that are looking to the screen where Francesca Cerbi is showing how to complete an anastomosis for bypass. So they can try by themselves the sutures, and they can try also the endovascular simulators. So this is only the hands-on part, because normally they spend 1 week every 36 hours per week in the hosting center to do procedures in the hospital. So to conclude, the mastery of vascular and endovascular neurosurgeon comes from the head and the heart, thinking through the right strategy and the best solution, and then striving to achieve a perfection. This was a statement said by Michael Loth. Thank you so much. I welcome to answer to your question.
Thank you for that amazing talk, Simon, and touching on some of the pitfalls we have today of how to get trained the forces around neurosurgeons training and practicing catheter-based treatment, and how to keep our skill set in microsurgery up. I really enjoy your method of training at multiple centers with multiple principals. In the US, mostly physicians train with 1 or 2 personnel to get this, but your way of going around multiple centers in a year, seeing different kinds of people operating is a very important thing. The few things that I would like to highlight from your talk, your skill set, you said you need open, you need endo, you need radiosurgery, which is a very important part of vascular disease, and critical care management is a very important part of vascular disease. So it's very important for, I wouldn't call them hybrid neurosurgeons. I see a comprehensive vascular specialist, right? You should be someone who comes with a vascular disease, whatever treatment they need, you should be able to offer it. That is where I think we should be, rather than, hey, I'm a hybrid neurosurgeon, I'm an intervention neurologist, I'm an intervention radiologist. That's not the thing. As neurosurgeons, we should be a master of the disease process and giving patients what they need to do. And along with that, the 2 other things we do is research and training. And you're focused on those 2 things. When I classify neurosurgeons, you classified hybrid versus dual. I kind of think about it, classifying it in a different way. If you take neurointerventional surgeons, and that comprises intervention neurologists, intervention radiologists, general neurosurgeons trained in endovascular specialty, and then neurosurgeons who have both microsurgical expertise and endovascular expertise. So there are 4 different categories in this. And then there are some cardiologists and even body IR people who do neurointervention, right? So that is the skill set on the endovascular side. Then you talk about microsurgical side, there are simple microsurgeons and then complex microsurgeons, right? The simple microsurgeons are people who can split a Sylvian fissure, get into the anterior fossa assistance, clip an MCA, PCOM, and then adds ability to do skull-based approaches, go to the brainstem, come down to the CV junction, go to the pineal region, do bypasses. Okay, that is complex advanced microsurgery. And there are people who live in different spectrums of endovascular capabilities and microsurgical capabilities. And we should try to climb that ladder as a hybrid neurosurgeon to do both, right? So that is the thing. And I think the field of vascular surgery is also expanding. Now we have stroke, we're going to have interventional oncology, we're going to have brain-computer interfaces and neuromodulation through catheters come very, very soon. We're going to access the cisternal spaces of the brain, transvascular, to do shunts. So this is just going to grow. And I think we need to embrace all of that and be a team player with all the people who are in this field.
I completely agree with you. Thank you so much. You got the point very.
Well, thank you very much. That was a wonderful lecture, and what followed was a wonderful, beautiful description and comments as well. We can open this for discussion. Yes, Professor Mathuria has raised his hand. Please.
Yes, I am Mathuria. Previously, I was in PGI Chandigarh till 2015. And actually, my statements may appear a bit radical on that. Please don't mind on that. Say the thing is that we should be focused on treating a lesion and a patient comprehensively, not competitively, irrespective of whether it is done by an endovascular person from the radiology stream or it is done by a neurology, neurosurgery stream, it doesn't matter. We should be comprehensive to each other. There are many things which are being done by them, not done by the neurosurgeons, so we take their help. And sorry, I'll take about 5 to 7 minutes on that. Say the thing is that we started endovascular neurosurgery in I don't call them radiology stream endovascular person. I all call them endovascular neurosurgeons, because after all, it's a neurosurgical problem which the endovascular person is treating or a neurosurgery stream person is treating. Clipping or coiling, that's a different story, but the endovascular thing is endovascular neurosurgery. We say we neurosurgeons started and supported endovascular neurosurgery in PGI Chandigarh, and at present they are doing everything. Till now also we are operating around 500 aneurysms a year, and we are coiling 150 aneurysms a year. Previously, there had spoiled the specialty quite a lot. Then we accepted that, okay, coiling is an accepted procedure, and there are many things which have come up in the coiling. Now they are putting the devices inside the aneurysm also. They are putting flow diverters and everything. So what I want to tell you is that whether it is a person from the endovascular radiology stream, neurology stream, or neurosurgery stream, they should be trained by the proper people. It should be hands-on training, may not be on simulator, may be on the patients, irrespective of whether the student is a neurologist or neurosurgeon and the teacher is a radiology stream, it doesn't matter. So we will have to stop this fight of the clinical stream versus the radiology stream. That is why we are trying to start a program in India that is called FNB, Fellowship in Neurovascular Intervention. That's what by the national board we are planning to start, and we have already started. There is some tussle going on, but probably we will try to resolve that tussle. And the radiology stream people are going to train the clinical stream people, and the clinical stream people are going to train the radiology stream people also at the proper centers. That is what is my vision. Then about the hybrid, say what I want to tell you is, when there is a person who is doing an endovascular thing, he is doing only endovascular, he is going to excel in the field far better than the person who is doing hybrid. I should trust in my colleague. If both of us decide about a patient, is this a patient fit for clipping? Is this a patient fit for coiling? Say, olden days when we used to talk, I used to talk to the HOD to see the opposite side of the neck of a broad neck aneurysm. And at present, you are unable to put the coil with the broad neck because the stent, etc., were not available at that time. Then we used to tell that I'll partially clip the aneurysm and you put the coil, I make the neck smaller. That sort of approach we should have. So that's what is my feeling. Most of the people may not agree to me, because my intention is treating a lesion and a patient with all perfection what we have in the world, irrespective of whether it is done by a vascular clinical stream or by a radiology stream person. Rather, it should be done comprehensive. Critical care I can provide better than the radiology stream people. So the patient is coiled, stented, then he comes to the neuro ICU in PGI, and we manage the patient. That's how we are running the program in PGI Chandigarh at present. I think you may agree to me on that. And as far as the starting by neurosurgeons is concerned, that time the radiology streams were not doing the things. So obviously it's a neurosurgical problem. Neurosurgeons have to start, but we have to accept the radiologist also. Be magnanimous, because these are our problems. Otherwise, tomorrow this fight is going to create problems for the specialty. What are your comments, Dr. Pastulo, on that?
Yeah, I agree with you. We should work all together in a multidisciplinary team. So that's very important. And also, I agree with you. And I said this in my lecture, that to achieve, in my opinion, to achieve the most highest level of the treatment, you should choose to do or vascular or endovascular. This is my experience, but you know, my inspiration model was the Barrow Institute model, where Michael Lawton is doing only open vascular treatments, and Felipe Albuquerque is doing only endovascular treatments. This is my idea, but I'm very happy that you agree with me. And but just let me underline a very important thing, that the master course is a 1-year course hosted in one of the hosting center. So every people have to be there in the hosting center all day long to do cases there, so they can have all they can train in this hosting center. Probably 1 year is not enough. It should be
it should be either 1.5 or 2 years. 1.5 is the deadline, and 2 years is the ideal thing. That's what, when I spoke to the endovascular persons, being a founder member of the Cerebrovascular Society of India, I had been struggling to create this model. When I talked to them, they told that 1.5 years is the deadline, and the ideal is 2 years. That's what should be the thing which should be done. And you know how the barrows has gone up in the vascular neurosurgery as far as the technology is concerned. They are not doing dual. Professor Robert Spechler, Dr. Michael Lawton, it's a great thing what they are doing. That's what we want the neurosurgeons to be all over the world when they are doing vascular. That's what we want to be, the intervention neurosurgeons to be all over the world. They should be doing the best, phenomenal thing to the critical lesions. And we have to cooperate with them and do it. It could be a radiologist team or it could be a neurology, neurosurgery team. The intensive care we can provide better, not the radiologist team.
So just a couple
That's
of
what we do in PGI. Why not all over the world?
Dr. Maturia, thank you for this discussion. So I completely agree with you that the training and collaboration and friendship between radiology, neurology, and neurosurgery has to be as you described. We should all work together. We are all treating the same patients. In fact, there are a lot of critical care certified neurologists who do critical care too, right? So I don't think critical care is just a neurosurgical specialty. Critical care is neurology and neurosurgery, right? So there is a lot of, working and
neuroanesthesia as well.
Correct, anesthesia as well. And then certification, I think, should come common certification between radiology, neurosurgery, and neurology. And there has been very good inroads into that. And Adnan Siddiqui, who has been my mentor, has been very instrumental in doing that in the United States. The one thing I would say is that I kind of disagree that, one person should do open and one person should do endo. I don't agree with that. I'll tell you my philosophy on this is slightly different. I think the endovascular should be part of basic neurosurgical training. It should not be a separate training. Just like you know how to use your pen field every day, you should know how to get femoral access every day. You should know how to take a catheter into the carotid every day. In fact, my residents, I tell them, you do a diagnostic with me, you come and do the clipping with me, you do the flow diversion with me, you see a patient in the clinic who has a brain aneurysm, we decide together what treatment needs to be done, and you come to me either to the angio suite or to the OR to do whatever you want with me. So endovascular training should not be just 1.5 years, it should be everyday neurosurgery. Right? You don't separate and say, I'm going to see only tumors for 1 year, only vascular for 1 year, only functional for 1 year. You don't do that in neurosurgery. Right? Just like that, endovascular should be everyday neurosurgery starting from the first year of your neurosurgical training. So it should be part of neurosurgical training. Right? And the ability to do both is very important on the microsurgical side too. Saying that you're a vascular surgeon and you don't do any tumors, you don't do any microvascular decompression, you don't do any other aspects of microsurgery other than vascular is a bad idea. Because as you said, that person is going to, in 10 years, become an endovascular specialist and not a dual trained specialist. Because if you just do open vascular surgery and you don't do anything else in open microsurgery, then your skill set in open vascular surgery is going to deteriorate. So you have to be a comprehensive microsurgeon, right? Where you do tumors, you do skull-based tumors, you do skull-based approaches, you do eloquent cortex tumors, you do pineal region tumors, you do all of that, and you do catheter-based treatment, right? So I think, the real hybrid surgeon is actually, in my opinion, you're a complex cranial generalist, not a specialist.
No, but endovascular should be a separate training. That's what I say.
There should be certification.
Okay.
There should be certification. But there should be basic endovascular skills that every neurosurgeon should learn.
Very well. That was very fruitful discussion. Now I think we can move on to the second session. And before we move on, I would like to mention to our viewers that this webinar is being broadcasted on YouTube, WeChat, and Zoom. Thanks to Professor Shubin for broadcasting this on the WeChat channel.
One thing, could
Yes.
could you have comments from Professor Yoko Kato on this sometimes, because she has been practicing vascular neurosurgery in the world all over. We can have her comments also sometimes on that, because this is something which is a burning topic all over the world.
Maybe we
Next
can
time when
invite
you are
her.
sending the
Definitely.
edited seminar, send her comments also. I'll appreciate.
Maybe we can do that. Thank you very much. So I'd like to inform our viewers that there are around 600 people who have joined us live from all around the world, and we'll move on to the second session. Professor Pestulo, thank you very much, and Professor Natarajan, thank you very much for this very wonderful
Thank you, Raja.
session.
Just a couple of seconds to say that we have had two neurosurgeons from India for this master course, and probably we should work all together with the Indian colleagues to create a common training program. So I'm very happy if you want to collaborate. Okay.
Thank you so much. The largest number of aneurysms are being operated in India in PGI Chandigarh even today, 500 every year.
Well, thank you very much for that very wonderful information.
Thank you so much for.
Now, I'm a product of PGI too. In fact, I was a resident in PGI when Dr. Mathuria was there, so I know him from those days. And I completely agree that, you know, training in neurosurgery and intervention in India, especially in PGI, should be the limelight, and I would be happy to help in any ways that need be.
I'd like to invite Professor Ramesh Nair and to say a short introduction and invite Professor Rupesh for his lecture.
Thanks, Raja. Thank you for this invitation to chair the session, and it was a great first session topic. And the next session is also a great topic. A lot of debate about endoscopic endonasal management of skull-based tumors, especially chordoma. And there are many dilemmas which we encounter when treating this nasty disease. And I'm very keen to hear from Professor Rupesh Kumar, who I met recently in Mumbai. And I invite Rupesh to share your screen and share your thoughts about the chordoma.
Good evening, Professor Nair. And at the outset, I would like to thank the ACNS, Professor Yoko Kato, Sir Raja, for giving this opportunity, this August forum, to speak on this topic. And it's indeed my privilege and pleasure to speak on this complex topic. As we know, skull-based chordomas are one of the most challenging diseases to manage. And a lot of, as Professor Nair was mentioning, there was a lot of ambiguity in treatment, managing, and there were a lot of approaches described in the skull-based era, lateral approaches, extended lateral approaches. Now, more and more approaches to these tumors are being done through endonasal corridors. And so I will focus on the endonasal approaches to these chordomas. They're not very common. As we all know, they are tumors arising from the notochord elements. And 1/3 of these chordomas do arise from clivus. Clivus is one of the commonest regions, followed by cervical vertebrae and sacrum. They are very highly aggressive tumors. As we know, recurrence is the norm. They are locally invasive. They're known for recurrence. The median survival has been dismal, and the 6.3 years with a 5-year survival of 36 to 68% in various reported literature and series. So we are dealing with a disease which is going to recur and which is going to be proliferative. So we need to make every stone unturned to catch this disease in early stage and then to potentially cure this patient if possible from outside. They're of course common in the 4 to 6 decades. Pediatric population do have this tumor, and the males are slightly more affected than the females. The most common symptom which patient presents are with the cranial nerve morbidity, most common being the 6th nerve. Some tumors do metastasize to the lungs, liver, and kidney, but they're not generally the norm. And this is the latest WHO classification of this chordoma. So the commonest being the conventional chordoma, otherwise previously termed as the chondroid chordoma. Now there's an entity called the poorly differentiated chordomas, which is quite rare. The collective cohesive epithelioid cells with eosinophilic cytoplasm, and they have INI staining. So it is important to differentiate these from other mesenchymal sarcomas. I'll come to you later the utility of brachyury. There is a small other subgroup called the de-differentiated chordomas, wherein you see islands of normal conventional chordoma and also see a poorly differentiated variant. So these are the three types of pathological variants of chordomas, which has been described in the latest WHO 2021 series. I'll want to stress upon this. Brachyury is emerged as an important diagnostic marker for chordomas. I'll tell you why, because many times there was some dilemma that this is, especially in pediatrics, we had a case where it was debated as whether it is an rhabdomyosarcoma, it was something else, because many sarcomas do occur in pediatric, the skull base. So brachyury can be very, very useful to differentiate, as majority of these chordomas express brachyury, and it can be taken as one of the pathognomonic features in chordomas. And even if it is a de-differentiated chordoma, they still retain brachyury, and so you will be able to differentiate when the diagnosis is in doubt. So coming to the imaging in chordomas, of course, the MRI is in limelight. MRI is the most useful and can tell us how much of the bone, how much of the soft tissue, how much it is intradural and how much it is stadural, how much of the extensions, craniocaudal, all these informations one can be able to see in the MRI. But there are some prognostic factors in the MRI, and I want to stress upon these two features. Number one is the enhancement. If you see an enhancement in the chordoma, then they are quite aggressive. They are going to behave aggressively. So there's one of the prognostic marker in radiology. The other important prognostic marker being the higher Pons to T2 signal. That is, the more the tumor is hyper intense on T2 in relation to the Pons, then they are going to be better prognosis. In other way, a hypo-intense lesion on T2 are going to be more aggressive, more cellular. So this is some of the differentiating or prognosticating factors even in chordomas. Now we have seen the prognostications in radiology. The same can apply to the pathology. So what are the aggressive variants in the chordoma as per pathology? So the tumor necrosis, the mitosis, and Ki67 proliferation more than 6% has been termed as a relatively aggressive disease. However, you also can see some of the good prognostic factors, something like a homozygous P21 deletion and 1p36 deletions. So they are independent prognostic factors for progression-free survival, and if you find them, they can be a better prognosticated disease. So these are some of the things which are new in this specialty and which is coming up very much. And now we'll focus on the principles of management. So as I was discussing, the cornerstone, a workhorse of these chordomas has been conventionally lateral skull base approaches, extended peterus, petrosectomies, and a lot of far lateral approaches for these Clival lesions. But in the last couple of decades, the focus has been slowly moving towards endonasal approaches, and there are a lot of advantages in endonasal corridors. So the principle should be supramaximal resection, something we describe in gliomas as supramaximal resection. So same thing do apply in chordomas whenever feasible. But whether it is feasible or not is a question, because the way they encase the vessels, the way they encase the disease, the skull base is quite not be possible in majority, but then there are some subset of patients where you can achieve this. The extent of resection is going to be one of the most important things. So whatever the bone surrounding the abnormal bone, if you can drill that, then that amounts to the supramaximal resection. Because we have seen in pathology that these tumors hide in the crevices in the bones. It's a normal appearing bone. So the drilling that extra corner of the bone can help in achieving a supramaximal resection in this disease. Now I'll focus on this topic on mainly the extended endonasal approaches to the clivus. So the clivus, so one of the workhorse for any skull-based lateral approaches we call the frontotemporoorbitozygomatic osteotomies, which can be really for reaching. The same way, between a pterional craniotomy and an FTOEZ, a conventional midline approach can be widened by this transpterygoid. So this is something synonymous with what we do FTOEZ for a skull-based lesion. This is for endonasal. So the transpterygoid approach can give a wide corridor uninstrumented, unhindered approach to the clivus, the clashing of instruments can be minimized and we can have a very good corridor. So I will focus today on this transpterygoid approaches to the clivus. So we know that the classification of the endoscopic classification of clivus into upper, middle, and lower third is according to these lines. So you draw two lines, one parallel to the floor of the sella and the other in parallel to the floor of sphenoid sinus. So though the part of the clivus which is above the first line is upper clivus, between the two lines, that is between the floor of sella and floor of sphenoid, constitutes the middle clivus, and something below the floor of sphenoid constitutes the lower clivus. So this is to for help planning the surgical corridor as to which is upper and middle and lower. Once you drill the bone, so this is what you see in the soft tissue. So these are the three endoscopically classified called clival lesions, upper, middle, and lower, the various nerves which you see in this corridor. This is the endoscopic view. As you see in the clivus, as you see a panoramic view you get once you go transpterygoid approaches to the clivus. I'll show you in my videos of how do we approach these in different lesions. So the transpterygoid approach is one of the important workhorse for this extended endonasal approaches to the clivus. And so this is the pictorial representation. As you see, the first picture sees that. So this is the craniocaudal view you see from superior. So this is the anterior. This is a maxilla. So this is the anterior, and then this is the posterior. So this is the medial, and this is lateral. So this is the end-on view from coronal aspect. You see this. So how do you do basically how do you do transpterygoid approach? Is that you do endoscopic maxillectomy. You remove the posterior wall of maxilla. And once you remove the posterior wall of maxilla, you enter into the pterygopalatine fossa. So once you reach the pterygopalatine fossa, and so you identify the Vidian nerve, which is one of the important landmarks. So which is the line demarcation between the horizontal and the vertical paraclival ICA. So once you identify the Vidian, which is going to be the very important landmark, and so this is the pictorial cadaveric pictures as you see here. So this is the clivus, this is sella floor, and you see this is the esopharynx. So this is the paraclival carotid on the left side, and this is the Vidian nerve, and the carotid turns laterally like this. And this is the pterygopalatine fossa contents. You dissect them and push them subperiosteally so that you will reach this. And once the drilling of this pterygoid plate can give you uninterrupted corridor to reach the clivus, especially the middle and the lower clivus, also to reach into the petrous apex. We call the far medial approach. So again, on the right side here, you can see the Vidian, the paraclival. The Vidian nerve constitutes an important landmark between the ascending vertical clival and the horizontal. Anything which is inferior and medial to the Vidian is very, very safe to drill and go, because the carotid already has gone laterally and you have very good corridor to work below this. So the Vidian nerve is the most important landmark. So the recent literature describes about this Velfa area. It's a mnemonic. So Velfa means the Vidian, the Eustachian, foramen lacerum, petroclival fissure, and pharyngobasilar fascia. So this is the picture. So your carotid artery, paraclival, ascending carotid artery, the horizontal ICA, and your Vidian nerve. So this is the anterior-posterior. So this is the Vidian nerve. So this is the area which is going to be the safe for drilling and for dissection, where you cannot encounter the ICA there. And this is the something called the Velfa area, which has been described. Now I'll go to the upper clival tumors. And this is one of the 24-year-old male who presented with this disease. You can see it's a recurrent. We can see this disease in the upper clivus, and it is involving the optic nerve, optic chiasm, and towards the right side of the ICA, slightly more eccentric on towards the right side. It is reaching till the basilar artery. So you can see here, so that's quite hypointense and it is quite firm. So we are going to be, unlike pituitary adenomas, chordomas are going to be very firm and hard. So they are not soft, suckable, or you cannot curate it out like a pituitary adenoma or a craniopharyngioma. So they are firm to hard tumors. So one need to have a very good exposure to work on these disease. And now the cornerstone of this treatment is proton therapy. And because this lesion is abutting the optic nerve here and optic chiasm, if you want to give a therapeutic dose of 75 gray, it's almost impossible to radiate this area. There will be a marginal failure, or if you try to radiate, you will develop severe optic radiation-induced optic. So the radiation oncologist also wants this disease to be cleared from the important vital structures so that they can deliver a therapeutic radiation, because they are relatively radiation resistant. Unless you have a high dose, these tumors are not going to go away. So we need to clear this tumor around the vital structures. I'll just take you to the video of this. So upper clival. So for upper clivals, you need not do a transpterygoid approach. And so this is the drilling of the sella. one need to have a good exposure of cella, the floor of cella, and you can see that the floor of cella is completely stripped, and you expose the clival paracellular carotid artery bone, you deroof it, and that is a dorsum cellae. So you do dorsal clinoid excision, and then you work. I just fast forward this video for time, and then you go ahead and remove this floor of cella, and you encounter. So some fat plug has been kept in the previous surgery in the center. So that is once you encounter this tumor like this, as you see, this is how the consistency is going to be. It's going to be firm, fibrous, and vascular hard. You cannot do curette, and you have to do berry picking. And here you can see that there's a dural defect there. So you identify the dural defect and you see, so that acts as a mark for you. So you know how far you have to go without injuring this. So the dura acts as a barrier in these tumors, and sometimes they go in. So you know how much the depth you have to go, because this is an oculomotor now, this is a brainstem, midbrain you're seeing, and there's a PCA. So you know how much the depth the tumor is going, and this acts, you put up the dissector on the intradural space, and then you can start working on it and start. So you know that you're quite safe in your tumor zone, and you're not breaching the dura anywhere. So you continue to remove this tumor, try to cure it as much as possible, and then try to deliver this tumor assets. You can see some part of the tumor are also calcified, and you then slowly you come around, you work around, and you can see that the whole dura is reflected after the tumor is removed, and then you continue to work. This is the supramaximal resection. So you continue to remove the normal bone surrounding, because you know that these tumors also extend the crevices of these tumors. So you have to remove the normal surrounding bone so that you are clearing the disease supramaximally. And you can see you burn out, you coagulate the dura attachment so that you try to burn the disease. And most important is that a robust reconstruction using multi-layered reconstruction using pedicle nasoseptal flap is very, very important, because these are the patients who are to go for radiation. Unless this wound is not going to heal, you are going to delay your therapy. So CSF leak and morbidity is going to be very high if there is a suboptimal packing, suboptimal reconstruction. So it's equal that how much you pay attention to tumor removal, same thing do for the reconstruction also. So that is the post-operative MRI. As you see here the disease has been completely cleared from the optic nerve chiasm, and you can see this disease is free, the pituitary stalk, pituitary. So here, this patient underwent a proton therapy for this tumor bed. As you see, you cannot eliminate this disease by surgery alone. So there are tumor cells hidden inside the bone, the dura. So one needs adjuvant therapy to clear this disease and to prolong their survival and disease-free, progression-free survival. So the proton has been given to this patient, and he's in 1 year follow-up. He's doing remarkably well. And so this is what we want to achieve. Clear this tumor so that they can give therapeutic dosage of up to 75 gray protons so that this tumor can be eliminated. So this is a tumor which is upper and mid clival chordoma. As you see here, this is slightly bigger tumor again, it's a recurrent. So you see here, so this is more in the midline, but slightly towards lateral. Is going to the subtemporal, extending towards the Michel's cave on to the left side. Always you see this, that you are seeing multiseptate. So, and especially we go endonasal, you have to have navigation, because sometimes we miss the other nodule completely. We think that we have removed the tumor and the larger chunk, and then surprisingly, we may lose behind the small nodule. So navigation is going to be helpful. We also have the practice that we do an intraoperative or perioperative MRI and make sure that we have removed the disease in toto, especially these chordomas when they are multiseptate. And so this is the navigation guidance, especially if it is a recurrent disease, the anatomy is lost. One need to have navigation to mark the clival carotid where it is so that you are safe, and then you continue to remove this tumor. And you can see that's the post-operative MRI. You can see that radical excision, complete clearance, and we can see optic nerve chiasm, subtemporal, hippocampus, everything is freed. It's important that this, compared to the previous, as you see here, the hippocampus is very, very close here, and this tumor is almost abutting that. So if we want to give a high therapeutic dosage of radiation, it should not spill over the dominant hippocampus. That is why it should be freed from this area so that the therapeutic dose of 70 to 75 gray can be given. Otherwise, there can be significant radiocognitive imbalance in these patients because they are young people who have their life ahead. So it's important that this tumor is radically removed, resected, and then subjected for radiation rather than radiating the disease as such. Now we'll come to the mid-clival tumors. So this is a girl, 13-year-old girl who presented with unilateral sixth nerve palsy, admitted biopsy elsewhere. They couldn't remove this tumor, and this patient was referred to us. And we can see here that this tumor is indenting the pons like this. The basilar artery is pushed, and you can see that there's the dura here, and you can see that the dura is defect in the dura, and this tumor has gone subdurally into the prepontine space. That is a sixth nerve here on this side, and this is the sixth nerve here. Probably the sixth nerve is getting caught here, and there's a fifth nerve. And you can see that this tumor, again, this is a soft tumor. The basilar artery is onto the left side. And this is the sagittal image. You can see here the bone is almost normal. It's not the bone, the clival bone you're still seeing. Only the inner table of the clival is involved with the tumor. You can see a huge expansive lesion here, convexity, and you can see that the dura is defect. And then this tumor is protruding and then burrowing into the pons, something like this. So it's important that you clear this. You cannot deliver protons here or radiation here. Otherwise, there can be radiation-induced brainstem necrosis, which can be fatal or it can be detrimental to the patient. So you remove this disease, clear this disease from the pons. That is very, very important. So one can argue which is the safest approach. I feel still the endonasal approach is the safest approach. It's a straight approach, but then you can combine it with the transpterygoid so that you can reach pons. I'll just take you to the video of this surgery. So you can see there's a bilateral transpterygoid approach. So here in the entire, as you see, the clivus was drilled because it's a thick clival bone. And after drilling the clivus, you can see the tumor is being removed beyond the clivus, the retroclival space. So you see this tumor is burying into the nooks and corners. So you try to scoop out this tumor. Luckily, this tumor is not very firm like the previous case. It's a little soft. So once you clear the disease in the extradural space, and that is the defect of the dura. So you go into the intradural, you find that the dura is defective, and you try to deliver this tumor in piecemeal. I can see that the arachnoid is coming out. Slowly, you're trying that this tumor is getting prolapsed into your space, what you have created. And then we can see that the arachnoid is protruded and that tumor, fortunately, you're not injured the arachnoid. There's no CSF leak. And so you try to deliver this tumor completely into the space which you have already provided by the tumor. So slowly, this tumor is getting protruded into the space. And then you're seeing the lot of tumor along with the arachnoid. So you have to be careful here not to injure the arachnoid. But at the same time, you have to remove this tumor in piecemeal, strip the arachnoid of this tumor because this can cause recurrence. So you try to preserve this arachnoid at the same time, try to preserve, not injure the arachnoid. So try to peel off the tumor capsule. And it's important that you push the arachnoid back because otherwise you'll not be able to reconstruct this. A patient can develop a pseudomeningocele and then can have CSF rhinorrhea. The gentle fat plug with the Surgicel, you gently push it into the space and then you provide a good gasket cover with an nasoseptal flap and that produces reconstruction. So this is the immediate post-operative MRI as you was mentioning earlier. You can see this tumor is completely removed. It's a fat graft and you can see this tumor which is burrowed into the pons has been removed and there's a small fat plug here. So this is very, very important so that now we can see there's a good space and then this patient had recovered from the sixth nerve paresis because of this. So this is another patient. And again, a mid-clival chordoma. And you see here that the same way, like the previous case, you can see this tumor is burrowing into the pons, something like similar previous case. But then this tumor has much more bigger components into the petrous apex, petroclival region, and also into the Michel's cave on the right side, and also into the innate. So here we need to be more aggressive. And he can see, I'll just take you to the video. You can see this nodule is a satellite nodule, which is going into the pons, burrowing into the pons. So like this. So again, this is the transpterygoid approach, and I'll show you the steps of transpterygoid approach. As you see here, so you try to, that is once you expose the cellular and then you work around laterally. So here the tumor is more towards the right. So that's the navigation place. So you know very much you drill. So you start drilling and you completely expose the paraclaval carotid. And you see here that is a carotid, paraclaval carotid. So that is a median nerve. So the median nerve, so the ICA will turn around. You're not identifying the ICA, only upper part. So the ICA will be somewhere here and lateral turns. So fast forwarding this video. So we can see that that is the petrous apex. So once you do the transpterygoid approach, you will be able to reach the petrous apex. So that is a petrous apex. You are comfortably, you are able to reach, fast forwarding it. So again, the principle is to remove all the disease in the extradural space before going to the intradural space. Try to remove this tumor. That is an angled scope. You are angling with the 30 degree and looking into the petrous apex, the petroclival apex. This is called the far medial approach. Something we describe microsurgically far lateral. This is a far medial. So that is a foramen lacerum, the cartilage of foramen lacerum. So you are removing so that you can remove this, clear this disease off there. So once you clear the extradural disease, now then you go into the intradural space. So that is the basilar artery, and you open the clival dura there because you need to remove this nodule which has gone into the pons burrowing into the thing. So you can see that you extend a little bit and then you're seeing the tumor there. It's a satellite nodule which is into the pons that has to be removed because you have to deliver the radiation. So that is a sixth nerve on the right side which you see. So you're removing the tumor in piecemeal. You're seeing the sixth nerve on the left side and which is lateral to this tumor. So you have cleared the tumor and again to have a nasal reconstruction. We also put a Foley's in place so that stays in for some time. And this is the post-operative, immediate perioperative MRI. You can see that there is a lot of fat graft here. There's a multi-layered reconstruction, which is very, very important. And you can see that the tumor burrowing into the pons has been removed. That is a small fat plug which was kept where the tumor was originally. And you can see the disease also into the disease in the Michel's cave also has been released. Extremely sorry. So this is the tumor which has been cleared in the right Michel's cave as well as in the petroclavian region, and the post-operative MRI. This patient also underwent subsequent radiation. Now we have seen upper clavicle chordomas, mid clavicle chordomas, now lower clavicle chordomas, and extending into the CV junction. This is again in this 37-year-old male presenting with hoarseness of voice, dysphagia, and we can see that this tumor is quite large, presenting with progressive ataxia, as evident because of the compression of the brainstem. The medulla is completely flattened over here. This tumor is large. It is pushing both vertebral arteries posteriorly, as you see here. And you can see multiple septations in this tumor. This is relatively soft. You can see again septations here, 2 septation, the 3rd septation. And we can see this is a large tumor involving the lower clavus, extending into the CV junction, the C1 and C2. And you can see that how the brainstem is deformed and distorted and pushed back posteriorly. Now you go to the video of this patient, again, a bilateral transpterygoid approach, and you can see that this tumor is more firmish and a little bit more. So you try to remove the tumor from the bones first, to try to remove this by transpterygoid approach. Here the C1 arch is being drilled because it's gone below the C2, and then the odontoidectomy, so endoscopic. So once you're done with the bony work, then you go into the dura. Here you can see that though we say chordomas are extradural disease, this tumor has gone significantly intradural and a thinned out arachnoid. So as you see here, you have started seeing the basilar artery, you have started seeing the pons lower aspect and the vertebral artery on the left, and you try to remove this multiple. You can see the septations here. That is one septae on the other septae here. You're trying to remove these septae, and once you can see that how the rootlets are involved, and you try to remove this tumor, cervical rootlet, the hypoglossal rootlets here, the vertebral artery here, and that is the medulla and upper cervical cord here. So you have a panoramic view by this transpterygoid approach, and we can see you try to remove this tumor as much as possible as can go. We can see because we have done the odontoidectomy, we were able to go below as much as possible. And we can see that is at the end of the tumor section, you can see the vertebral artery on both the sides. That is the lower cranial nerves on the left side. And you can see very good with the angle scope, you can able to see both vertebral visceral junction. And we can see that all the tumor has been released and removed. So we have an endoscopy. This is an idea. You can go to the nooks and corners, use angled scopes, angle section, and try to release this tumor in all the hidden crevices, and you have a panoramic approach. So here, the multi-layered reconstruction, you can see this is an artificial dura. So it's an inlay technique and followed by multi-layered reconstruction. This is a gasket, contain nasal cartilage bone, and then you have fat, and then you have this nasoseptal pedicle flap. So this is a multi-layered reconstruction. This is very, very useful and helpful to prevent CSF leaks because they are highly prone to have CSF leaks in this, especially in this area. So this is a post-operative MRI. This is the fat suppressed contrast image. As you see here, this is all the fat, and we can see this tumor is almost clear. There's a suspicious nodule over here, and we can see that this fat is there in the fat suppressed, in the non-fat suppressed image. And you can see, however, the brainstem has come back to its original position, and we can see this tumor significantly empty into the premedullary space of both vertebral arteries. You can see it's tumor free. So this approach of a transpterygoid, you can see we can have a very wide approach. And this is again another gentleman who presented with a residual, already undergone a far lateral approach, tried to remove this tumor, but then there was a residue which was growing. And as you see here, again, the clavus, lower clavus going up to the C1, C2, you can see something similar to the previous case, but it is also extending the mid-claval, the medulla pons being pushed posteriorly. And this is an enhancing tumor. So as I was mentioning you, the chordomas which are enhancing are more aggressive compared to non-enhancing chordomas. And here, what you see here is the past 2 cases, you saw the tumor burrowing into the pons. Here you are seeing the tumor burrowing into the medulla, and you can see that displaying the both vertebral arteries, and here medulla is being burrowed, and we can see this is an enhancing the disease. So again, a transpterygoid approach. So this is the sphenoid osteo. So this is a workhorse for us, and we can see this is the pterygoid plate. So I'll just fast forward this. So the pterygoid is being drilled, and we can see once the pterygoid is being drilled, it's untethering. So you can get a wide access laterally. So this part of the bone is easy to drill, and there are no specific important structures here. And then you can see, so once the pterygoid plates are drilled, you can see you can go into the lower clavus with ease. And once you have a wide exposure, and then you start removing this tumor and piecemeal, again, you see this is a firm tumor, firmish, and this is already operated, so a lot of additions. And we can see a glimpse of vertebral artery there, and that is a vertebral artery. And the right side, and you can see this sperm, so that is the medulla oblongata. And we can see that this tumor, this is a nodule which is burrowing into the medulla. So you try to go into the inferior aspect. Here you are using more of a sharp dissection because it is very firm and fibrous. And this is the tumor which is burrowing into the medulla. You put a plate dissector. So the same microsurgical principles. So two-hand technique helps most of these times. So you have always worked with your ENT colleague who can help you with exposures, and you can help so that we can have a two-hand technique to dissect the tumor like this, something like a sharp dissection, so that we don't blindly pull and injure the vertebral artery or its perforators. So you can see it's utmost care and precaution. We need to clear this tumor from the medulla. Because we saw that this tumor was going down below the C2, so we odontoid drilling, and then we extend the dural incision below to make sure that we catch the lowermost part of the tumor. So we can see once we know that we have reached the lower aspect, and we can see that almost from the mid-claval to the C1, C2 we have reached, and then reconstruction, again, solid reconstruction with multi-layered reconstruction as was mentioned in the previous slide. So this is a comparison. So this is the previous preoperative MRI. As you see here, burrowing into the medulla, and we can see that it's a post-operative MRI. You can see that all this bone has been removed, and we can see it's nicely reconstructed with the multi-layered reconstruction. And you see how much the tumor, the medulla and pons has been decompressed, including the upper cervical cord. And we can see the tumor which was burrowing into the medulla has been removed, and you can see that the medulla is now free, and both the vertebral arteries are free. So transpterygoid approaches gives a very good exposure to safely extirpate these tumors from these regions. Some tumors don't behave, these boundaries are upper or middle or lower. Some are really giant. And as you see some of these tumors like this, really giant chordomas. And we can see that luckily they're not much compression into the neurostructures, but then they occupy the nasopharynx and also into the clivus. The whole clivus is involved by the disease. This patient presented with dysphagia. As you see, there's a tongue of tumor going into the oropharynx. He presented with dysphagia, not neurogenic, it was a mechanical dysphagia. And as you see here, this tumor going again beyond and the dense process, and you can see that the whole dura, luckily these are all extradural disease. There is suspicion that this part of the dura can gone extradural, subdurally. This is the postoperative MRI, as you see here, almost cleared till the medulla, and you can see a wide bilateral transpterygoid approach to access this tumor, and also this tumor into the nasopharynx has been cleared. The dysphagia improved, and is quite comfortable discharge. This is one, sometimes we think that the chordomas are not vascular, and so this is one case which was operated outside, and the procedure was abandoned because of extreme vascularity. There was profuse bleeding. The patient was started biopsy, so the surgeon packed it, and then this patient then came to us, and then we saw that this is a large tumor, enhancing tumor. Again, we know enhancing tumors are not good, and they are aggressive, and we did an DSA, and we could find that there's a lot of blush of this tumor. That is by the previous center, because of vascularity, that this procedure was abandoned. As you see here, the blush of vessels could be, majority of this blush could be embolized preoperatively, and we took up this case for surgery. And we can see there's a perioperative MRI. So we could remove most of this bulk of the disease, though there are some disease into the foramen lacerum area, which this patient has subsequently underwent proton therapy. So a word about this protons in chordomas. So proton therapy is one of the indications for chordomas, and it's a modality of choice because we know that chordomas are radio resistant. It is not really radio resistant. It means that it requires a higher dose of radiation. So that is why these tumors are labeled as a radio resistant disease. So protons has a distinct advantage of being super selective and also with a low entry dose and maximum energy deposition at the target. And we can go doses as high as 75 gray, and that which is required to eliminate these chordomas. And the mean dose is somewhere between 72 gray. And with the advances of proton world over globally, the overall survival has improved remarkably in this difficult disease. So to conclude, there is no paradigm shift of chordoma surgery from lateral microsurgical approaches to endonasal approaches. So more and more of these diseases are now being done endoscopically, and endonasal approaches are preferred. It's better to have a multidisciplinary team work with an ENT colleague who is well-versed in skull-based techniques, so that is a complementary to each other. So it can help in exposures and reconstruction, and you can concentrate and you can perform as a microsurgery through an endonasal corridor. You have an excellent visualization through endoscopic approach and a transpsyrigoid approach untethers or detethers the region, and you can go uninterrupted without crowding of instruments and with much better exposures. You can reach these tumors in laterally as well as craniocaudal. As mentioned, it is not just the tumor removal. The most important is here also to reconstruct the dura, because clival duras, clival CSF leaks are very notorious for meningitis, and they can cause mortalities, and it delays the adjuvant therapy. So it's important that due respect is given for reconstruction. There's always a multi-layered reconstruction using fascia, fat, inlay, outlay, a preferable casket technique, and also vascularized flaps whenever feasible. So thank you everybody for this opportunity. I'm okay for taking some questions.
Thank you, Professor Rupesh Kumar. That was a brilliant talk. I think this is a talk which was very comprehensive and should be watched by all the neurosurgeons starting out extended endonasal approaches especially for clival lesions. Clival lesions, especially chordomas, can be a vexing problem. And as Prof. Rupesh said, maximal clearance is the best chance of having an extended survival in this case. And for that, especially for lower clivals, as you can see from the beautiful videos, the lateral view you get by taking off the pterygoid wedge and extending your clival gives you the maximum chance of clearing out the disease. And some of the other salient points about the histopathology and the confusion regarding some of the cases where you don't know whether it's a chordoma or chondrosarcoma, especially before the operation, even after the operation, you will be worried about it. And there's been some dilemma whether in the past, whether to biopsy it. I think the standard practice in cases where there is a dilemma, it is a reasonable thing. I think it's a sensible thing to biopsy it without causing a lot of spill, and try to resect the whole tract when you want to go back and resect it completely. I think also you talked about the use of navigation in cases, but I think especially in recurrent chordomas, which can be a difficult problem with the involvement of the carotid arteries, one has to really have a good navigation to make sure that you don't have a vascular injury. And also sometimes I feel that in massive tumors, it will be good to perform the DSA and also to get a balloon occlusion test just in case you want to know the cost circulation and keep the endovascular interventionist standby. I think it's a good practice to have this multidisciplinary approach which you talked about, having the END support and the endovascular support. So these patients have to come back because they get a lot of cutting and they need to have proper follow-up to the END surgeon, which will be useful to have them for the surgery as well. And these cases will require a lot of repair at the end of the operation. And one thing which you notice is that sometimes with the wide clival planned clivectomy, you get a kind of prolapse. So you need to have sort of fat support to the repair you did after the operation. So I thank you for this talk. And that's one thing which I often get asked about is the role of resecting the dura. When you resect tumor, sometimes you find that it is attached to the outer layer. And as you know, as an oncology part of the oncological kind of way of dealing with the chordoma is to try and resect everything. But as soon as you go over the next layer of dura, then that's the next level of operation with all the attendant risks that you come across. Sometimes you reach a stage where you will be wondering, especially for smaller chordomas where it is attached to the outer layer, you have to resect it. My policy has been to try and be more aggressive than normal. I don't know what you do, Rupesh, in such circumstances, whether you would try and be more aggressive or resect the dura, or you try to preserve it first time.
Yeah. So it all depends on how we see the dura. Previously, conventionally, we were thinking that dura is all clival chordoma or extradural disease, and the dura is most often intact. But many times we see that they do behave intradurally. As you see in one of the primary cases I showed you, the tumor was completely intradural. So where is the dura there? So the tumor probably has been eroded the dura, or the dura has been partly thinned out because of long-standing disease. And what you see is that the bone, the tumor, and then the arachnoid there. So that means that we are already removed the tumor along with the dura. But there are cases where, which I showed in the first case, the upper clavicle, the dura in the upper clavicle, the cellular, the dura was intact. So the tumor was more onto the right side. So I put a dissector into the intradural space. I know where the tumor ends with the dissector. So I was trying to remove this tumor extradurally, and then trying to pull. Once the tumor got prolapsed, the dura was shrunk, and you can see that the whole dura was coagulated. Some dura, in fact, the anterior part was resected, but then we leave some dura coagulated because we are not sure, because sometimes we may think that the reconstruction may sometimes be problematic in some cases. So those abnormal looking dura are excised, but then those dura which looks really normal, we can just coagulate and leave it. And in the small girl, we saw there is dura, small prolapse, the arachnoid was intact. So we tried to preserve the arachnoid, but then we didn't want to leave the islands of tumor inside the arachnoid before pushing the arachnoid. So we tried to strip the tumor off the arachnoid as much as possible, so that once we push back the arachnoid, so it's a mix and match. So preoperative decision making is also crucial. So as we know how much the dura or the bone is involved. But the key is that we just don't restrict the bony removal, because primarily chordomas are bony disease rather than the dural disease. So the bone removal is important, even if the normal looking bone surrounding, going around and drilling the bone surrounding where the tumors are, that actually helps in eliminating the microscopic invasions of this tumor analysis.
Yeah, thank you. Prof. Mathuria, you want to come in? I can see your hand is up.
I just wanted to know, is there any difference in histology of the tumors which are going intradural versus the tumors which are limiting outside the dura?
Yes, sir. So we had a separate pathology talk on this. So we compared those tumors which are intradural, and both the majority of our cases were conventional chordomas. And we could, when we gave to the pathologists, when we asked them, they couldn't differentiate. They were biased. So we didn't tell them that it was intradural. So they couldn't find any difference between an intradural disease as an extradural disease. So for them, it's a conventional chordomas. We had challenge only in one case wherein it was a young child, 2 years, and the tumor was biopsied. They thought it is like a rhabdomyosarcoma of the clivus. So the patient was referred to us. There was a bulky disease in the clivus because it was only biopsy. So we went ahead and decompressed the tumor as much as possible, and then we cleared it. And the outside report was RMS, rhabdomyosarcoma, which is quite common in the pediatric age group. But then when we studied, the markers for RMS came negative. But the brachyury was a turning point. So brachyury was densely positive, which is negative in RMS. So actually it was a dedifferentiated chordoma. So the dedifferentiated chordomas, especially, it can happen in very, very young children like this. And they sometimes mimic rhabdomyosarcoma. They can be erroneously diagnosed as RMS or any other mesenchymal sarcoma. So brachyury, even though they are dedifferentiated, brachyury can still be retained. So brachyury is very, very essential to clinch the diagnosis if there is any ambiguity in diagnosis.
Thank you. Any other comment or questions?
Sir, I have a question.
Yes, go ahead.
My name is Afsar Sharaf, and I'm currently a fellow at Professor Kato's department, and a very good greetings to all the distinguished professors and other fellows, other colleagues around the world. So my question is, as you said a few times, chordomas tend to recur more often than not. And if you have a complex case that you already operated with a complex dura reconstruction, and if you have to, like, say, choose the same corridor, how challenging is the dura reconstruction after the radiation and perhaps a lot of scar tissue? How do you go about it? And I have one more question. And if you have a large chordoma also infiltrating the upper cervical vertebra, say C1, C2, and if the complete resection demands, or like if the complete resection would lead to an instability, would you like stabilize the cervical vertebra prior to removing the tumor? How do you go about it? Thank you very much.
Yeah. Okay. Yes, Dr. Sharaf. So the first question is whether you want to, what is your strategies in recurrent chordomas, especially So I was working in a center, Apollo Proton Center before, so where we used to get a lot of references of chordomas because being a proton therapy unit, the majority of these cases were recurrent, operated elsewhere, biopsied or partially resected or recurred after radiation. So we had quite challenging thing to manage. So we differentiated tumors whether they are post-radiation or not. If the tumor has not been irradiated, then there is a much better chance of reconstruction than, because if it is radiated, then it's really challenging. But still, endonasal approach is very good because the vascularity still remains. So if somebody has already utilized the nasoseptal flap and you don't have a vascularized flap, so that will be a major challenge. So we have a wonderful ENT colleague with me, Krupashankar. So he's, what he does is that he does a turbinate flap. So if there is no nasoseptal flap, majority of the time you see that just a roomy nose, there's nothing, and then you see the tumor. So that is a real challenge. So where so you harvest the whole mucosa or the floor of the nostril, and then you try to rotate it using the cartilage. And then these patients require multimodal, so multiple inlay with a collagen sheet, and then the fat, and then the gasket technique. So what in our practice, those cases where we don't use gasket technique, we had found 2 cases we had CSF leaks, and both the cases the gasket technique failed. So gasket technique really helps, especially if it is a radiated. That it's like a bath plug technique. So where you take a facial lata, and then you try to take a bone, especially nasal cartilage, and then you snugly fit in and gently, carefully, so that the pulsations are prevented. So what we do then is put a fat, and then we use again a fascia, and then we put nasoseptal flap or the nasal floor of the nasal flap or turbinate flap, which is vascularized. We use a police balloon inflated, and we keep it for up to 72 hours. We have not used lumbar drain in majority of our cases. Almost we have stopped the practice because a bath plug technique with using a gasket technique actually helps if there is no lumbar drain, because the flow of CSF helps to plug the defect more and more. So we avoid lumbar drain in all these cases, especially successfully in gasket technique. Now, of course, coming to the question of your second question, that is how much you can go down instability. So as we see, we drill the bone from superior inferiorly. So C1 arch, we don't disturb much the ligaments. So we drill the C1 arch anteriorly and we go down directly into the odontoid. So there you don't really damage the ligaments. So we have stabilization, but many times the patients already with the stabilization done outside. So that means we just have to go ahead. But then we have 2 cases, especially upper cervical cord. Patient was stabilized, had a very, very stiff neck. So for resect these tumors, endonasal we couldn't reach because it was going down to the C3-4. So we did, maybe another occasion I can show those videos. So we did a transglossal, transmandibular, transpharyngeal approach. We have completely through the pharynx. We removed the tumor up to C3 because the limit through transnasal is C2. You're not able to reach the tumor if it goes beyond the odontoid and below, wherein you have to use a transglossal approach and transpharyngeal approach. And then again, you need a plastic reconstruction using fibular graft. So it all depends on how much where the tumor is extending. But if you're restricting your resection only to the odents, generally you don't need stabilization because you're not disturbing the ligament.
Okay. Thank you. Thank you very much. Any other questions before? I don't see any other questions.
Atik has raised his hand. Dr. Atik?
Yeah.
Do you have any?
Thank you, Professor. It was an brilliant presentation. Basically, you have answered 2 of my questions from the questions of Afzal. My last question is, do you sometimes practice stitches the dura when there is chance of high CSF bleeding?
I have seen a Japanese neurosurgeon, Dr. Takio Gato, uses this. Yeah. So, but I have not tried. And most of the times in chordoma, the dura is either infiltrated or they're damaged completely. So you don't need dural margin to suture the dural defect. You can do if it is a tuberculous meningioma or craniopharyngioma, especially. Craniopharyngioma, the dura is intact, where you may still be able to close. But in chordomas, your aim is to also remove the dura or cauterize the dura so that you clear the disease. So there is no scope, I feel, in suturing the dura in a chordoma.
Okay, and you have 2 cases of CSF leak. How did you manage those cases?
Yeah, so there is no question of putting lumbar drain waiting. If there is a CSF leak, you go in. Again, repack it. You see
re-exploration.
Re-exploration. We don't wait in a Clival CSF leak. Do not wait. Unlike a transplant, you wait, put lumbar drain, wait. Clival locks are not going to heal. So Clival, if there is a leak, you go in and don't hesitate to go in. Again, identify the defect, put some more fascia fat, identify the area, and place the Foley's catheter bulb inflated after your plug-in technique. That really helps.
Do you think that putting a Foley's catheter hampers vascularization of the heart flap?
Yes. You have to, it's not like you're completely filling it up and distending it. So, and moreover, you're not going to plug the vascularity area. So the nasoseptal flap. So it is going to be where exactly you are going to be in the inferior aspect where there is vascularity is not really going to be compromised. So it's quite safe. So in a Clival effect, we don't do routinely, only we do if we are not able to succeed in our gasket technique. If you have a gasket technique in place, you don't need the Foley's catheter. That is
yeah. That is my point. Thank
you.
Yeah,
and also when you put the Foley's catheter, then make sure that the catheter, the balloon is not really pushing onto the pedicle, which is turning inward. That's the point where you sometimes get a compression and pedicle ischemia. So I think the technique of putting the Foley's catheter is important as well.
Yeah. Thank you, Professor.
All right. I think thank you, Prof. Rupesh Kumar, and I think that was a great talk on chordomas, and we will conclude this session. And I really enjoyed it, and a great discussion after the talk as well. And back to you, Raja.
Well, thank you. We enjoyed too. It was really a wonderful presentation, and thanks to Professor Rupesh and Professor Ramesh for this wonderful session. Now I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Simon Pestillo and Professor Rupesh Kumar, as well as the chairs, Professor Sabarish Natarajan and Professor Ramesh Nair, for the time and support for the ACNS webinars. And also special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.